talk this morning is the approach to mild asthma. How much is too much? So this is the last known picture of the Titanic on the surface of the ocean. And 3 days after this picture was taken, it hit an iceberg in the early morning of 1912. And as we all know, it sank. And together with it, it brought 1,514 people. So today, the same number of people die from asthma worldwide. And this should actually remind us that asthma is a real problem and we cannot ignore it. So this is the outline of my talk. I will talk a little bit about the pathophysiology of asthma, and I will bring you through the definition of mild asthma, maybe some information on whether we can or cannot ignore mild asthma, and the pitfalls in managing mild asthma. So I'll start off by stating the very obvious, which is that asthma is a chronic inflammatory airway disease, and we are well aware of that. When we talk about asthma, the people usually use the term atopic asthma or extrinsic asthma, and this is the more common of the two. And the inflammation is mediated by systemic IgE production. The other type of asthma is a non-atopic asthma, and it's otherwise known as intrinsic asthma. It's less common, and the inflammation is mediated by local IgE production. So what happens in the bronchioles of asthmatic patients? First, there is increase in the number of goblet cells, and this leads to increased mucus production. There is also an increase in eosinophils in the mucus as well as the tissue, and there is increase in mast cells in the lamina propria, and this leads to an increase in histamine release. There is increase in a plethora of other cells, notably the neutrophils as well as the T helper cells, and in terms of the smooth muscles, there appears to be hypertrophy. So this is just a diagrammatic pictorial showing the cross-section of the airways in an asthmatic patient and a non-asthmatic. And what you can obviously see is that the lumen is actually narrow. So remember all these things that happen in asthmatic bronchioles. What it leads to is the three characteristics of asthma, which is airflow obstruction, and bronchial hyperreactivity, as well as bronchial inflammation. So over here, the arrow shows a narrower lumen, and this hyperreactivity is the reason why we actually have symptoms that wax and wane, and during periods, they can be almost well. So this picture was taken from nature, and this shows a cross-section of a normal airway, and we compare it to the cross-section of an airway in a patient with severe asthma. So you can see that over here, there is remodeling of the airway with, again, narrowing of the lumen, and there is actually mucus metaplasia. There is also an increase in the smooth muscle, you can see over here, as well as very obvious fibrosis and angiogenesis. Again, this leads to narrowing of the airway and leading to symptoms that the patients have. So what are the players in pathophysiology of asthma? There is the IgE antibodies, there is the mast cells, and together the mast cell IgE complex actually produces a lot of problems, right? Other important players are eosinophils and dendritic cells. Of course, we cannot forget the T helper cells, and it's divided into Th1 and Th2 helper cells. The Th1 helper cells are normally found in the lungs, and they promote inflammation by cell-mediated immunity. What about the Th2 cells? Well, in asthma, there is an imbalance. So what happens is the T helper Th2 cells, which are not normally found in the lungs, are upregulated. And they in turn promote inflammation by humoral immunity, i.e. antibody production. So just have a look at the pathway of type 2 inflammation, in particular, otherwise known as eosinophilic pathway. So we have the lumen, your mucus, and the columnar epithelium, and you have your allergen. So when the allergen is inhaled, it is actually engulfed by the dendritic cells, and the dendritic cells then release chemoattractants, causes the Th2 helper cells recruitment, and the secretion of cytokines, the IL-5, which is secreted, promotes eosinophil production. The IL-13 and IL-14 then promotes recruitment of the plasma cells and production of antibodies. The IL-9 goes on to the mast cells, and this causes degranulation of the mast cells, leading to release of histamine, prostaglandin, and leukotrienes, and this in turn leads to airway bronchoconstriction. So there's the other thing about the thymic stromal lymphocytes, which is actually expressed in the epithelial cells, and this are like a IL-7-like cytokine, and I think this is central to the regulation of allergic asthma. So just move on to my next slide. So this is actually a nicer diagram compared to the one that was drawn before. Again, this highlights that there are many pathways in the pathogenesis of asthma. You can see that there's a lot of cytokine release with a lot of crisscross of airways. So it suffices to know that the pathway is complex, and in certain patients, some pathways are the predominant ones, and this is where the targeting of biologics come into play. So let's move on to asthma. What is asthma? It is actually important disease worldwide. I hope I've convinced you by the number of deaths that we have in a year, equivalent to people that we lost in the Titanic. It's also heterogeneous, meaning that you'll have various patients who have got asthma, who've got different manifestations of the clinical symptoms of asthma, and in terms of the predominant pathway and in terms of the treatment. Now, over the years, we have had many developments in terms of what is the pathophysiology of asthma, and along with that, the treatment of asthma has improved. Currently, there is greater appreciation of the importance of inhaled corticosteroids as a basis of asthma treatment. So I think diagnosis of asthma requires the documentation of excessive airway variability. So I think most of us are familiar with the post-bronchodilator reversibility test, otherwise known as a spirometry, where you actually look at the level of the FEV1 and the amount of air. So if you have an increase of 12% and 200 mils after a bronchodilator challenge in an adult, then this tells you that the airway is reversible. Sometimes when you don't have spirometry, you can actually use peak flow, and what you aim to actually dissect is that a patient would have an average daily diurnal variability of more than 10% in adults. Other tests that are available would be you can actually give the patient an anti-inflammatory treatment and you see an improvement, and by that you can say that there is presence of airway reversibility. There's a positive exercise challenge test, and there's where you do the opposite when you actually have a positive bronchial challenge test, and this is actually done by inhalation of hypertonic saline or mannitol challenge, and this is actually done in Hospital Serdang. Okay. So first, before you diagnose asthma, you need a history. You need to actually document that the airway is reversible, and then you can actually move on. So the diagnosis of asthma, I'm going to show you a video of the reversibility. I'm just going to decrease the volume first. Okay, so this is a person doing a spirometry. You can see that there's a lot of effort, and the person who's actually doing it also has a lot of effort, and he looks absolutely exhausted after that. So spirometry is actually very effort dependent. And who needs to do the work? The person who actually performs the spirometry, as well as the person actually doing the spirometry, right? So with that in mind, there are many errors in spirometry that will actually cause differences in your reading. So when you actually order a spirometry, it's important that the technician doing it is a trained technician so that the values are actually true. The other way of looking at asthma, diagnosing asthma from the GINA guidelines, they do accept what is known as the FeNO test. So FeNO is fractional exhaled nitric oxide, and it's actually a marker of inflammation, meaning the higher the value, the more inflamed your airway is, and we know that asthma is an inflamed airway. So a value of 40 parts per billion or more tells you that it favors asthma. So let us have a look at this girl who is actually going to do the FeNO test. Right, so you can see that she's taking her time, putting it in. Look at the effort, very minimal, nice blowing. She's supposed to blow the balloon across in a very steady flow, very steady flow. You look at that, very little effort on her. And she stops when the balloon has reached the opposite side of the swamp or the drain. Okay, so I think this highlights that the different tests that you can do to look at reversibility of airway, and it's important to note that spirometry is effort dependent. So what would we do when we are faced with a patient with asthma? You have to assess the control of asthma. If the diagnosis is actually certain, you want to see what the control of asthma is like. And the tools that we frequently use are the asthma control test, otherwise known as the ACT, or the asthma control questionnaire, otherwise known as the ACQ. So this is the ACT. So basically it's simple. It's a validated instrument. There are 5 questions and it's based on symptoms of nighttime, daytime, rescue bronchodilator use, and daily activities. As in anything, a higher the score, the better. So the cutoff is actually 19. If your score is 19 or less, that means that the patient's asthma is not well controlled, and this is a self-administered survey. If you do not like this, you can actually use the asthma control questionnaire, which is a 7-item questionnaire, and it's based on daytime and nighttime symptoms, daily activities, as well as rescue bronchodilator. So this picture just highlights that the ACT has been validated in various languages. You can see that this is actually English in the past 4 weeks, or you can choose Malay dalam 4 minggu kebelakangan, or you can actually choose Chinese. Right? So this is what we give the patient. As I mentioned before, it's self-administered. So they are supposed to decide in each of the 5 questions which one of the options best suits them in terms of their control in the last 4 months preceding the time that they actually presented to the clinic. Apart from the control of asthma, the other important thing is actually to look at the risk of future risk of exacerbation. So this is taken from the GINA guidelines 2021. And it's important to note that if you have uncontrolled asthma symptoms, that in itself is a major risk factor that you will go on to get exacerbations, right? Other things would be medication. So there's a lot of interest in terms of the overuse of SABA. High SABA use, which is has been shown to be associated with increased risk of exacerbations and mortality. So I think when you see a patient with asthma in your clinic, it's important to ask them about their SABA use, and if they're actually using more than 3 canisters per month, more than 3 canisters per year, you probably need to think whether they're actually having risk factor of risk of asthma exacerbation. We also look at comorbidities of obesity, chronic rhinosinusitis, GERD, or confirmed allergies. Pregnancy itself is a risk for asthma exacerbations. We know that 1/3 of patients with asthma will go on to have increased exacerbations throughout the period of pregnancy. If they smoke, they should stop smoking. And if they actually have lower socioeconomic problems, they are at risk of getting asthma exacerbations. So when we look at lung function, actually a very low FEV1 or very reversible airway tells us that this patient's potentially going to run into problems, right? If they've ever, so in the history, you want to ask about their intubation or severe exacerbation in the last 12 months. Again, these are risk factors that increases the patient's risk for asthma exacerbation. So this is a study that we undertook, and UKM was actually part of this study, looking at the risk of short-acting beta-2 agonists. This was presented at the APSR last year in 2021. So what it showed was that this was a cross-sectional study, and it involved Malaysia, and we contributed one of the most patients actually. So Malaysia, India, South Korea, Thailand, Taiwan, the Philippines, Indonesia, and Singapore. So I think we cannot ignore the fact that almost 30% of patients, right, 26.1 patients, they actually had SABA prescriptions of more or 3 or more canisters per year, which in itself was regarded as potential SABA overuse. So what is the role of lung function in asthma control? Number one, it does not correlate well with asthma symptoms. It should be assessed at diagnosis, of course, and at start of treatment. And we usually do it 3 to 6 months to ascertain the patient's personal best and periodically thereafter. But in the era of COVID, we have been advised to do it. We can actually get away with not doing it because doing this test would require a PCR test and additional cost on the patient. So the values that you get would be the FEV1, the FVC, and over it, we can actually calculate the ratio. The predicted values are what the patient should be able to achieve given the right height, sex, and age. And this is what is measured. So usually we'll look at the FEV1. So you can see immediately that the ratio is actually less than 70, which tells us the obstructive picture. And the FEV1 is less than 80%, whereas the FVC is not affected. So this patient has got an obstructive lung disease. So how do you interpret? Well, if there's a low FEV1, then you identify the patient at risk, especially if the FEV1 is less than 60% predicted. There's a risk for exacerbations and for lung function decline. If the patient's a normal FEV1, you probably want to think of alternative diagnosis of asthma. If the patient has persistent bronchodilator reversibility, meaning when you repeat the spirometries periodically, it's always very reversible at 12% with 200 mils from baseline, this suggests that this patient has got what we know as uncontrolled asthma. So what are the questions we ask? We want to assess the asthma control using the ACT. You want to assess the treatment issues, meaning you want to document what medication the patient is on. You want to watch the inhaler technique. You also want to assess the adherence and the side effects and look at the patient's attitudes and the goals that the patients want to achieve, whether they actually meet your goals as well. Most of the time we forget to do this, but it's important to look at the comorbidities of rhinitis, rhinosinusitis, reflux, obesity, concurrent diseases such as obstructive sleep apnea, depression, and anxiety, which can contribute to the symptoms and lead to poor quality of life in patients. So this is just a collection of pictures of patients that I've seen in my clinic, and each and every one of them have got bad inhaler technique. So you can see that they come in different races, different sex, so it doesn't matter, and different education level. But inhaler technique is something that we should actually check in clinic. So I'm just going to show a video of a patient with inhaler technique that is not so good, right? So you can see that she puffs, inhales too fast, and she stops over there, right? So the problems with that would be that she didn't take a breath out first, and then she puts it in. She's supposed to actually press the inhaler and inhale very slowly, right? So the slower the inhalation, the better. And she's supposed to count up to 10, although some papers tell us you hold your breath for 6 is enough. So again, she looks like quite a sensible lady with glasses on her head. She looks okay, but yet her inhaler technique is not okay. So when we assess asthma severity, it's actually a static feature, and we look at it retrospectively from the level of treatment required. So we assess the patient once the patient has been on the controller treatment for several months, and if appropriate, when the treatment has been stepped down, attempt to find the patient's minimum effective level of asthma. And this is when we actually say what asthma severity the patient's at. So how do you know when a patient's got mild asthma? First of all, caveat, mild asthma is present in as much as 50 to 75% of patients with asthma, so we can't ignore it. And asthma severity is actually based on steps. So if you are well controlled at step 1 or step 2, you are mild. If you are well controlled requiring treatment at step 3 and 4, you're moderate asthma. If you have severe asthma, it means that either we have actually stepped up the therapy and you still remain uncontrolled, or you need high dose ICS LABA to prevent from being uncontrolled. So today, for the purpose of this talk, we will concentrate on mild asthma, which is asthma that is well controlled at step 1 or step 2 of treatment. So historically, treatment of mild asthma has always been focused on SABA, right? As needed rapid acting beta-2 antagonists. But over the years, in 2008, there have been, based on papers which I'll share later, other control options which have come into play. So they actually say consider low dose ICS in the year 2018. And in the year 2019, there was the most fundamental change in asthma management, where treatment in step 1 now favors as needed inhaled corticosteroids together with formoterol whenever SABA is taken. So you have a look at the GINA guidelines in 2019. Lo and behold, in step 1 is a little bit different. What is the preferred controller now? As needed low dose ICS formoterol. So ICS LABA, but the caveat is the LABA must be formoterol, because formoterol is the only LABA with a fast mode of action able to actually give good relief of symptoms. So in 2019, this was the main difference in terms of step 1 therapy, meaning that in mild asthma, you don't use SABA anymore. You consider as your preferred controller as needed low dose ICS LABA formoterol. In 2021, you notice that they divided it into different tracks. So track 1 is over here, where you use low dose ICS formoterol as a reliever, and they state that this is actually the preferred reliever recommended by GINA. And track 2 is actually, if you're going to use SABA, you're going to use SABA as reliever. You take the ICS whenever SABA is taken. So it's a change of what we've been taught as medical students, as MOs, as specialists, right? That you no longer should have a patient on SABA monotherapy. If they take SABA, they should take ICS whenever they take SABA. So this is the main difference in the 2021 guidelines. So let's look at the clinical vignette. Madam KM, 67, asthmatic, ACT score 25, currently on low dose ICS formoterol PRN basis, 1 ICU admission 4 months ago. How do we translate that? We translate that to the fact that because of her medication, she's got mild asthma, good asthma symptom control, but yet we have to look at the risk of future exacerbation. She is at increased risk of future exacerbation because she has had a severe exacerbation within the last 1 year, leading to an ICU admission. So I think it's important to note that patients underestimate their symptoms. So having a look at this study in UK of 1,000 asthmatic patients, you can see the symptoms are wheeziness, tight chest, cough, and breathlessness. Patients who felt well actually had wheeziness, tight chestness, and cough and breathlessness. But yet when asked, they said that they were well. So it's important to note that a lot of our patients who say they're unwell actually do have symptoms. So just go on to some of the lessons learned on studies of mild asthma. The first trial that I would like to share would be the Optima trial, which was published in 2001. And this was a study involving 1,970 mild asthma patients from 17 countries. And group A was actually in terms of the steroid naive, and they actually had 3 arms. One was the very low dose budesonide. The second was budesonide together with formoterol, and the third was actually the placebo. Right? So what did they find? In the placebo group, number one, a lot of them actually had severe asthma exacerbations. These are mild asthma patients, right? And asthma control was poorly controlled in about 14.4% of days. But when we look at the group A, you can see that the low dose budesonide alone reduced the risk of first severe asthma exacerbation by 60% and the rate of poorly controlled asthma days by 48% compared to placebo. So we know that mild asthma patients have got symptoms, and the introduction of low dose ICS actually had very good decrease in risk of asthma exacerbations. This is another study which was published in 2003, again looking at mild persistent asthma, and the patients were followed up for 3 years. So they found that budesonide significantly reduced the risk of first severe asthma-related event by 44% for all patients, and 47% for patients who were actually having pre-bronchodilator FEV1 of more than 80%, and who were actually steroid naive at entry. So you can see from this graph that there was a prolonged time to first asthma exacerbation, as well as this. If we have a look at these patients on budesonide had significantly more symptom-free days during the whole study period up to 3 years than those on placebo. So what did they conclude? That once daily, low-dose budesonide decreased the risk of severe exacerbations and the need for systemic glucocorticosteroids in mild asthma patients and improve overall asthma control. The other study I want to share is in the year 2005, where we have a look at daily versus as needed corticosteroids, again for mild persistent asthma. So they evaluated the efficacy of intermittent short course corticosteroid therapy, which was guided by the patient's symptoms. And these were what the patients were allowed to take, either open label budesonide for 10 days or prednisolone at 0.5 milligrams per kilogram of body weight for 5 days if the symptoms worsen. So the study involved 225 patients with mild persistent asthma, and what it showed was there was no clinical significant difference between the 3 treatment group in terms of the peak expiratory flow. So this shows that the novel approach to treat persistent asthma, symptom-driven intermittent treatment with inhaled and oral corticosteroids may be possible. Then we move on to the more recent study, 2017, on the Sigma study. And what it showed was that the ICS LABA on a PRN basis was superior to SABA alone in terms of well-controlled asthma weeks. And in Sigma 2, it showed that it was non-inferior to low-dose ICS plus SABA in terms of annual severe exacerbations. So both these studies actually looked at patients with budesonide formoterol as needed, and they found that they had actually a 17% risk reduction in terms of severe asthma exacerbation and a 3% risk reduction in the Sigma 2. So ICS formoterol on a PRN basis was equivalent to budesonide maintenance BD in both Sigma 1 and 2 at preventing severe exacerbation. So this tells us that the PRN compared to a regular dose can actually still decrease severe exacerbations in mild asthma. And in terms of the patients on budesonide formoterol, they had a 64% lower severe exacerbation rate compared to our famous SABA alone. Right? So this should convince you that intermittent therapy is important. Now, this is a recent study in 2021 looking at asthma patients as well as the physician's perspective on the burden and management of asthma. So we know that the 2021 GINA recommends as needed inhaled corticosteroids, ICS formoterol, irrespective of severity, maintenance, and reliever therapy. So MAT is called that, right? So they recommend that. So this study aimed to actually explore patients' perspective as well as physicians' perspective. So in this study, if you have a look at the mild asthma patients, meaning the patients on GINA steps 1 and 2, which were about 736 patients, the majority of them were actually only on inhaled SABA, and only a small percentage of them were actually on MAT therapy. So this study is otherwise known as the apparent study, and what it found was that actually most patients prioritize symptom control over reducing exacerbations, which is not quite correct. We should aim for both. Patients also considered symptom relief to be important, and physicians classified a substantial proportion of patients as GINA step 3 and higher. Now, importantly, a large number of both physicians and patients were not aware of this new way of using it, which is the MAT therapy. And because of that, most physicians had prescribed an additional as needed reliever alongside MAT. So this is the problem, right? So my take-home message is that asthma is common. It's a chronic inflammatory airway disease. It's characterized by unpredictable episodes of worsening of symptoms and exacerbations. There is a disconnect between asthma control and patients' perception. I think the proactive management of patients with mild asthma using regular ICS is actually important, and we need to educate both asthmatic patients as well as physicians who treat asthma on the management of mild asthma, to improve the management overall. So with this, I would like to thank you for listening. And this is a picture of my patient in the ward. When he was asked what medication he took, he was confused. So we gathered all the medication that he had at home and lined them up and asked him which one he was taking. So this actually just proves that it's important to review your patient's medication. With that, thank you very much.